Good afternoon or good evening. I'd like to thank the organizers for allowing me to speak and giving me the opportunity to speak. We saved the best for last, I guess, so we're here to talk about EP as the best for last, so let's move on. I would like to start out by defining electrical storm. So electrical storm is defined as 3 or more VT episodes or VF events within 24 hours requiring intervention. And that could be ICD shocks, it could be external shocks, and although this is what we define as electrical storm in the setting of a stable patient, a lot of times when we see patients in the ICU in cardiogenic shock, there's kind of a subacute electrical storm where patients are getting shocked once a day, once every other day. So it's a fluid definition, but we call electrical storm 3 or more VT or VF episodes. The incidence of electrical storm is 10 to 20% in patients with secondary prevention and about 4% in patients for primary prevention. Of course, these are in stable patients who are implanted who are implanted ICDs. In the setting of cardiogenic shock, we don't have a good incidence. The epidemiology of which is not well known, but I would gather to say that the incidence is significantly higher. 80 to 90% or 97% of the arrhythmias in electrical storm are monomorphic, and the triggering mechanisms are identified only in about 10 to 25% of patients. There's a high mortality with patients with electrical storm. About 34% of patients die in follow-up. And again, I'm sure in the setting of cardiogenic shock, this is a much higher percentage. The mechanisms for ventricular arrhythmias are 3. So monomorphic VT, which constitutes the most frequent form of arrhythmia that we see in cardiogenic shock patients with electrical storm, is usually caused by reentry within a myocardial scar or with an injured tissue. In ischemic cardiomyopathy patients, there's predominantly a subendocardial scar. They're more amenable to catheter ablation. In non-ischemic cardiomyopathies, 50% of the myocardial scars are epicardial or mid-myocardial, and although these are also amenable to ablation, it's a little more complicated, as you saw from the previous case study, to ablate these patients, and the complication rate can be slightly higher. Polymorphic ventricular tachycardia can be caused by ischemia, by electrolyte imbalances, medications or drugs. They're usually associated with long or prolonged QT intervals and are not amenable to ablation per se. And then finally, ventricular fibrillation, which can be seen caused by PVCs from the Purkinje fiber, automaticity or triggered activity coming from ischemic myocardial tissue, often resolves over time if there's an acute event like a myocardial infarction, but sometimes may last even for several days or weeks afterwards. It can also be amenable to ablation. So again, the issue we have with electrical storm is that the studies for electrical storm in the setting of cardiogenic shock are lacking. The management of electrical storm depends heavily upon the mechanism. Traditional therapies like beta blockers and sympathetic blockade is not always a good idea, and actually probably contraindicated in settings of cardiogenic shock. As mentioned in the case study, multidisciplinary approach is acquired. You'll see we often heart failure cardiologists, interventional cardiologists, electrophysiologists, anesthesiologists, CV surgeons, all of us have to get together to help make decisions for these patients. And ablation is a well-established therapy and is actually used as first-line therapy in many patient populations. But these are always in stable patients. So we've always looked at stable patients for VT ablations. The role of ablation in cardiogenic shock, again, is unknown, but tends to be considered high risk. So this is what I call the VT cardiogenic shock spiral. So usually we have VT results in an ICD shock or an external shock, both of which result in some myocardial stenting or injury. This leads to LV systolic dysfunction as well as RV dysfunction. It elevates LV pressures, results in cardiogenic shock, or at least contributes to cardiogenic shock, leads to an adrenergic state, hypoperfusion, ischemia, which worsens the VT, and then the spiral continues onwards. I adapted this from the 2017 ACC Guidelines for management of VT for specifically cardiogenic shock. But there are no guidelines for VT storm management in cardiogenic shock, so we'll take it from here. So electrical storm can be managed based on the mechanism. So if it's polymorphic VT or VF, then the first thing to do is consider reversible causes. And the easiest thing to reverse is electrolyte imbalances, can discontinue drugs that are causing prolonged QT intervals. If there's a need to revascularize the patient, take the patient to the cath lab, do an angiogram, revascularize the patient. But if there's no reversible cause, then we have to start looking at other options. So amiodarone and lidocaine are often the drugs of choice. Actually, we use both of them frequently, so the combination of two works synergistically together. Anesthesia is useful. We usually recommend general anesthesia with deep sedation. Hemodynamic support with intra-aortic balloon pumps, Impella or Tandem. I'm not going to go into great detail regarding these because I have experts here who can talk about these at greater length than me. And then overdrive pacing, either with temporary pacing or if you have an ICD, pacing from the device at rapid rates to try to suppress PVCs or ventricular arrhythmias. Now, if the VT is not controlled despite these interventions at that point, then I think you have to go and look for an identifiable PVC trigger. If you see an identifiable PVC trigger, then it's catheter ablation may be the best option for you at that point, and I think you may have to do an emergent ablation. If there's no identifiable PVC trigger or there's multiple PVC triggers, then autonomic modulation can be attempted, and I'll go into greater detail what type of autonomic modulation there is. Monomorphic VT, we start off with antiarrhythmic drugs, but I like to put this as a tree because I don't think you start with one or the other. You kind of do as much as you can at the time, depending on the patient condition. So again, amiodarone, lidocaine, but procainamide can also be used. And again, the combination of amiodarone and lidocaine is also useful. Again, hemodynamic support is useful as well. General anesthesia is often needed. That not only results in reduced VT episodes, but of course, reduces the discomfort and pain from external shocks or ICD shocks. And then device programming, either overdrive pacing, but also programming ATP so that you can terminate these types of tachycardias without ICD shocks. Again, if the VT is not controlled, then we head to catheter ablation. I'm not going to talk a lot about hemodynamic support because I think we've already talked a lot about hemodynamic support. So I'm just going to talk about the other types of VT suppression therapy that are available. So antiarrhythmic drugs we've talked about to an extent. So amiodarone, lidocaine, and procainamide are the drugs of choice. I wouldn't use procainamide necessarily for PVC-mediated VF, but it can be used for monomorphic VT, which is the predominant VT that we see. The problem with antiarrhythmic drugs is sometimes they don't completely suppress the arrhythmias and they can slow down the cycle length of the VT. So you just turn it from a fast VT to a slow VT, which is good for us because that allows us to ablate the arrhythmia a little bit easier, but nonetheless, it doesn't completely eliminate the issues regarding electrical storm. Device reprogramming or programming. So I would recommend get your APs involved early, get the device programmed so that ATP can be programmed to the device to terminate the VT prior to delivering ICD shocks. You can also do overdrive pacing through the ICD or with a temporary externalized pacemaker. The only issue is that prolonged RV pacing really rapidly can also worsen LV systolic performance, so I think you have to be careful. If you want to do this, you can do it for a short period of time, but it can worsen the cardiogenic shock. And again, we talked about general anesthesia, and then autonomic modulation. There are really two different forms. One is stellate ganglion block, and the other one is thoracic epidural anesthesia. Stellate ganglion block is a technique that's done by an anesthesiologist. It's an effective technique. It's used for short-term termination of electrical storm. You basically anesthetize the left stellate ganglion block in the neck. It results in a Horner syndrome on that side. And it works. It's useful to perform. It's quick and easy to do. It literally provides some level of relief for patients for at least about, I would say, about 5 to 6 days. Can be repeated again as well. This is a study we're looking at left stellate ganglion block. This is a single patient looking at the effects of VT, lidocaine, and procainamide, and this is again in a stable patient. This is not in the setting of cardiogenic shock, and they used beryllium here, which is not available anymore. The LSG that's reported there, that's left stellate ganglion block, and you can see the episodes of VF per day reduced dramatically with this. And again, as time goes on and the left stellate ganglion block dissipates, the VT starts to come back. You can re-perform the left stellate ganglion block, and that tends to eliminate the episodes. This is a study looking at sympathetic blockade, again in stable patients where they were using propranolol and esmolol. All right, very well. Anyways, I think that got most of the stuff there. So, okay, very well. I'm open for questions. Any questions?
How
Yes,
I have
Ivan.
a question for you.
Yes.
AMI, VT arrhythmias, and acute on chronic systolic heart failure arrhythmias are two different beasts. So you revascularize, they have VT arrhythmias, there's hope for that ventricle to recover. So what's your strategy? Do you just put them on MCS and give them Lido and Amio to cool them down? Or is it better to give them or think outside the box and think in terms of ablative options in the hope that they don't get shocked and they would further cause myocardial depression?
I think in the early stages after an acute MI, it's always good to cool the patient down. And a lot of the arrhythmias, they do self-terminate. So I think it's when, you're on 4 to 5 days past the event that you're not getting the patient out of the ICU, you're not able to wean off hemodynamic support, or you're not able to wean off the IV antiarrhythmic drugs. That's when you start looking at more creative options or using ablation as an option to try to treat these patients.
I have a question also regarding, in my experience, and I think we're seeing more and more of these patients. I think we're sort of creating a whole group of patients now that are out there with ICDs, with chronic heart failure, and they end up in this situation. We always do a coronary angiogram, and if it's not in the setting of acute MI, but they have chronic occlusions, they're revascularized. And in my experience, the effect of that on the arrhythmia is limited at, very limited at best. Can you comment on that, or what should we expect from that?
Yes, actually, I'm glad that you brought that up, because I have a tough time explaining to some of the interventionalists that monomorphic ventricular tachycardia, particularly slow monomorphic VT, is scar-mediated. So the alleviating acute ischemia can sometimes alleviate the triggers that cause the VT to occur, but the scar circuit is still there. We're talking about reentrant mechanism in that scar and through a scar. And Dr. Harry Rahn probably will go into greater detail on how to ablate that type of patient. But opening CTOs or revascularizing patients in a non-acute setting doesn't always result in VT suppression. In fact, rarely does.